Hey guys, welcome back to my channel. Today we are discussing the anomalies of placenta. First four anomalies we have discussed earlier, and placenta accreta we will explain later in detail. So comes to circumvallate placenta. There is basically a term extracorporeal placenta, and it's two types, circumvallate and circummarginate. Normally, area-wise, fetal part is equals to the maternal part. If fetal part is smaller, that is chorionic plate, then the maternal surface, that is basal plate. If this transition is smooth, then it is known as circummarginate placenta. It means the wall-like thickening is absent. I written this is here, and if wall-like thickening is absent, wall-like thickening is present, then it is known as circumvallate. In this, fetal part is slightly depressed, and in circummarginate they both are at the same level. Now what will happen if circumvallate and circummarginate condition appear? There will be less blood goes to the fetus because fetal side is small, and there will be less urine. It will eventually lead to oligohydramnios and lead to preterm labor. So next, there is placenta succenturiata. Placenta succenturiata, one or more accessory lobes are present. Now there is a term placenta spuria and placenta bilobata. We will discuss the difference between them. Placenta succenturiata and placenta spuria, there is connecting vessel is absent in spuria and present in the succenturiata, and in both the small part separated from the main part. But in placenta bilobata, as seen in this, the both part are the equal and connected with the vessels, and like this there is tripartite placenta also. Now next, battledore placenta. Battledore placenta, there is marginal insertion of the cord, and it can lead to cord avulsion, bleeding, and fetal distress. Next, placenta membranica. In this, placenta cover the entire uterine cavity, but the main pathology behind is this. Normally, the fetal side of the placenta develop from the chorion frondosum, and chorion levae form the fetal membrane. If the placenta develop from both chorion frondosum and chorion levae, then this type will cover the entire uterus, and it will be thin and membrane-like. It can also lead to placenta previa and accreta. Now, velamentous insertion. We discussed here only the pathology, because the main this topic we explain in detail in our next video. In this, the cord first attached to membrane and then to placenta. When the membrane ruptures, the cord is injured, and we know that the cord has umbilical artery and umbilical vein. It will lead to fetal loss and vasa previa. There will be increased rate of placental abruption is prematurely separation of the placenta, and it can lead to decidual hemorrhage. These are the risk factors: smoking, trauma, and hypertension. these are the old diagrams. That's it for today. Tomorrow we discuss the placental hormones and placenta accreta and vasa previa. Then this topic will be finished. Okay, thank you. So our next and most important topic is placenta previa and placenta abruption. It is the most important topic and every time asked in NEET PG and inicet also. Let's discuss this. Placenta previa, it is insidious in onset. That means bleeding. Bleeding is always visible. Bright red in color. It is the painless. This is the main point here. This is painless. Uterus is soft and relaxed. Fetal heart rate in normal range. And its fetal presentation may be breech and transverse lie, and engagement is absent because placenta is present near the internal os. It has different types and stages. Placenta abruption, it is sudden in onset. Bleeding is concealed and can be visible. Dark in color. Uterine tenderness or palpation present. It is fetal distress is present and maybe fetal heart sound is absent. There is no role of fetal presentation here. Our next topic is placental circulation. Placental circulation has two parts, maternal, which is known as the uteroplacental unit, and fetal circulation known as fetal placental unit. In maternal circulation, the blood comes from the uterine artery, which is oxygenated blood, and goes to the intravillous space. And from this intravillous space, the blood is diffused into the chorionic villi and comes to the fetus by umbilical vein. Then from the fetus, deoxygenated blood goes to the placenta, and from placenta it takes taken by uterine vein into the maternal blood. In this way the blood circulates. The most important thing here is note that the umbilical vein carry the oxygenated blood and umbilical artery carry the deoxygenated blood. Usually the vein carry deoxygenated blood and artery carry oxygen, but here is reversed, so keep this in mind. This is a picture of the placenta which shows the maternal surface and has cotyledon. 15 to 20 are normal, and these are rough surface, and here is smooth shiny gray surface of the fetal side. Now we have the next topic, methods of placenta. There are two types, Schultz method and Duncan method. Schultz method has central separation of the placenta as shown here. There is central separation of the placenta first. There is retroplacental clot is formed. Bleeding will be less and bleeding visible when the entire placenta separates. This blood is shiny fetal blood, but in Duncan method there is peripheral separation and no retroplacental clot is formed. Bleeding is more and bleeding is evident as the placenta starts shedding. This is the dull red color blood comes from the maternal side. Duncan type is less common, more dangerous. So next I have made few MCQs which help you in your further tests and exams. So let's read it quickly. First, placenta is completely formed by, answer is 12 weeks. Fetal part we already know, it's formed by chorion frondosum. Maternal part is deciduum basilis. Placental weight at term, it's 500 gram, 15 to 20 cotyledons. Gaseous exchange occur at intervillous space. Most important question, which antibody crosses the placenta? That is IgG. Placental hormone we discussed in our next video, which cause the insulin resistant, that is human placental lactogen, and earliest hormone is HCG. Placental barrier becomes thin in third trimester. There is no direct mixing of blood because of the placental barrier. I already told you. The most important question is most common abnormal cord insertion is battledore placenta, and most dangerous one is velamentous insertion. Placenta accreta, definitions given here. Then placenta previa, its answer bleeding is painless and bright red. Next is placenta implanted in lower uterine segment, known as placenta previa. Placenta insufficiency leads to IUGR. Retained placenta basically is placenta accreta. Corona levae, I have already discussed, it forms the membranous part of the placenta, so it forms the non-placental part, that is membrane covering over the placenta. Then placental weight is approximately 1/6 of the fetus. This is the last minute neat month. All we have to remember about the placenta. Important things. 12 weeks, 500 gram, 20 cotyledon, IgG, HCG and intervillous. In our next video, we discuss the placental hormone and placenta accreta and vasa previa. Those who don't have time for the long videos, I am putting one-liner MCQs in my shorts. So please go and watch and follow and subscribe my channel for more videos. Thank you.